I'm going to do everything I can to not put epi down the tube. But is there any research to suggest delays in epinephrine would be worse than putting it down the tube? I don't think they've studied it, but the reason for the large volume of epi down the tube, because we know we need more volume for it to be absorbed in that area, but absorption's already kind of impaired in this state in pathology. And the HA guidelines and the ILCOR guidelines suggest like IV and IO routes are far superior for the circumstance. So it's like the last resort, as you said. But let's make it operational. So I'm going to start prepping in my mind. It's like, okay, this person needs to be intubated due to these reasons because the IGL's not working or the supraglottic's not working or they're contraindicated. So I need to optimize my success. So I want to put them in the best sniffing position possible to align all the three axes, right? But I'll do the caveat. What if we find them in a lake or they jumped, then they drowned? Like, do they have a C-spine injury that I have to consider, which overall makes my airway management harder? So these are considerations to take away. If not, again, just get them in the best sniffing position possible. Like that's 20% gets you 80% of the results. Like literally just aligning their axes makes a significant improvement. And I always tell paramedics or any novice intubators, the most common thing we do is we get really close to the mouth, but then you just obscure your view. So you got to think like you're in the OR still. You got to go back to actually see down the vocal cords to make sure you can see what you've aligned. Then, if I could, I would use a video laryngoscope because we know in the pre-hospital setting and most in-hospital settings, like you improve your first pass success rate with them. And I'd definitely use a bougie. That's my bias. I think my bias can be substantiated with using for like improving your first pass success rate because I like that extra confirmation. I like that if it's a pretty interior airway, I can get it in. I can maybe feel the tactile rings. So I would use that. Then I would just have suctioning nearby. And if you had the ability to do the salad technique, 100%, and just have somebody beside you being able to apply cricoid pressure and being able to assist with suctioning and passing the tube and everything. Would you add anything to that?
No, I 100% agree with you, and your biases line up well with mine. Absolutely, I think video laryngoscopy would play a very powerful role in managing these patients specifically, like you said, with that C spine, the potential C spine trauma, depending on the kind of mechanism of injury. Um, sure, we do want to minimize movement to their C spine in those cases. I'm not going to argue against that under any circumstances. Um, so, video laryngoscopy allows you to put a lot less pressure on the airway and allows you to not have to manipulate structures as aggressively. That's been shown in like mannequins that like measured the amount of force that was put through the mannequin and the amount of movement of the head as well. So that's definitely beneficial. However, I'd say um, as long as you're not making like big adjustments to the movement of their head, their injuries already occurred. So it's way more important that you prevent those secondary injuries than it is to like make sure you don't move their neck by a couple millimeters or centimeters, right? Because if you don't get them oxygenated and ventilated, they're not going to ROSC. There's going to be no positive outcome whatsoever. So we need to kind of balance out the risk benefit there, right? Yeah, the rest of that is music to my ears. Absolutely, what I've been trying to say. So that's great.
Let's go one more layer deep. So just thinking about the prep and everything, because that's honestly half the skill too. Because I'm sure we've all been in the mouth. You're like, oh crap, I can see it, but I don't have a 10 cc syringe ready. Standardization practice is good, but I would try to use the video laryngoscope. But if I knew it obscured the camera from like a bad airway or soiled airway, I would have my direct laryngoscope beside me, just so it's there in case I had to switch. And I'd also have a couple tube sizes beside me as well, because again, I may have to switch or that just may be a bigger, smaller airway. And I'd try to get in any tube that I could at that point. Probably a lot of services are going to be mad at me so that I'm increasing their wastage and making the truck messier, which I was notoriously known for. But again, I just want every tool right there so I don't have to go hunting for it in times of dire distress. And that takes away a cognitive load too that I'm prepped. And as I get my equipment set up, I can help rehearse in my mind what I want to do.
Yeah, 100%. So, preparation for intubation and using that team approach is one of the biggest interventions you can make to your practice that does not rely on buying a new fancy piece of equipment, uh, or going to some training course or whatever. That can have a significant impact on your first pass success, and especially in these cases can have a significant impact on the patient's outcome. At least we could extrapolate that and logically assume that. So that's why we talk about not rushing to this skill. You want to also empower the other paramedics that are on scene to help you temporize what's going on. So, like, if I show up to that drowning patient, um, my partners are going to, deal with the airway before I do, probably. They're going to, suction, BVM, supraglottic airways, things like that. They're experts at airway management within their scope. They're like, I fully trust that that's going to happen. It's going to happen well. And then I can move to, scene management stuff, getting access, IV, IO, giving that first dose of drugs. And now this is awesome. We've got everything kind of set up so that we have a good foundational resuscitation. And now we have room to think about what's the ways that I can optimize this, right? Creating that space is really important from a human factors perspective. And then I can say, cool, I have like 4 minutes to prepare 2 tube sizes, to get my VL, to get my DL, to position the patient, to get my bougie. Everything's set up. I've got suction ready, make sure we've got a fresh canister, like all those little logistics things that can pile up and create a lot of big problems. Create that space, look at the call. Um, you can really prepare yourself to, first pass success that way. So I guess that'd be my little tidbit there.
I love this because we're actually getting pretty deep with it. And if I could add a couple things too for the listeners, like this is what I would do. And I found it helped me and helped them as a good team approach. Whoever's my partner, whether it's ACP, PCP, I'd be like, listen, this is my approach. Like, I'm going to go in. If you don't mind holding suctioning, if I say apply burp pressure, this is what I want you to do for these reasons. And I may ask you to give me the 6 tube, the 7 tube, or whatever equipment, just depending on what I see. So everyone's kind of knowing what you're doing. Because how many times we've been on a call where like, I have no idea what they're thinking right now. So just you get it out there. Those are the expectations. Or you say too, like, do you have any thoughts or questions or considerations? So everyone's kind of on the same page. And it's like, I actually care what you think and want for this situation. Even at, like working with another ACP, it's like, I think we need to prioritize the airway due to these reasons. I think we need to move to an intubation due to these reasons. What do you think? So everyone's on the same page. And that's also helping you rehearse and maybe check any blind spots that you're having.
Yeah, 100%. And I think, checking in with whoever's at the airway, like you said, ACP, PCP doesn't really matter. It's like, hey, whoever's at the airway, are you guys happy with what's going on there? Is there anything I can do to help? And they say, yeah, we're good. We're thriving. Okay, cool. Now I don't have to worry about that. We'll check in again for sure. But I can think about other things, right? Space because they've competently managed it and know what's going on.
And I know it sounds so simple and almost cliche and patronizing to say, "Hey, I'm checking in," but no, like surgeons do this, anesthesiologists do this, the top trauma programs in the country do this, and it's like, of course, it's like, "Hey, I just want to check in. How's it going? You need help? What are you finding up there?" Because imagine you went through the whole call and there was a problem and you had no idea about it, you'd be kicking yourself, right?
100%. And I mean, like, yeah, we say it's kind of cliche, but this is what all high performance teams use. Like, I'm sure Ben could talk to you about special operations forces doing this exact type of communication, like in combat, and this is what works in high performance teams. So we should definitely try to emulate that as much as we can.
Yeah, and I always like to rant about this because it's funny. I always say this, like one of my profs left that, in any other profession, they'd say, you can't change stuff because of culture. They'd laugh you out of the room. But in healthcare culture, it seems to be just abundant and we can't change it because in special ops or in aviation, no matter the mission, they always have a debrief. They're like, no matter what, everyone's for it. Let's go over this, see what works, what didn't work, so we can learn for the next time. Imagine you said that in healthcare, and it was like, man, I just worked 14 hours. Peace. Like, I'm done with this call. And it's like, I can appreciate it, but It's just the difference of mindsets and the expectations, right?
100%. And I think, on a positive note, I'm definitely seeing a lot of that change. There is a culture shift kind of on the way from my microcosm that I can see, those debriefs happening and people helping each other out and um trying to learn from every critically, or high acuity call like this. I think that's shifting and we're learning from those other industries. So,
I couldn't agree more. The focus on just culture, patient safety. Let's learn. Like we all are fallible, and these calls will happen, and we need to learn from them. So let's do it together. And before I forget, what do you think about putting epi down the tube? Like, let's say I nailed this tube. Now I know any delay in epi is problematic. So I have a route here.
mhm.
Should I just dump this epi down the tube?
Yeah, let's do that. Let's put epi in with our lake water and see how it'll somehow get absorbed and it'll be great. No, I don't think that in the IO era, um, there's a place for that really anymore. I would rather get an IO started on like any age patient than do that because you might as well just not really give the epi, especially because like these are you're going to be doing a lot of suctioning, so you're suctioning, you're deep suctioning, you're going to throw some epi down there, and it's such a high volume, especially right relative, especially for pediatrics. No, I'm not a fan. I don't think it really has a role now that we have IOs. Um, what are your thoughts? I know that's a kind of strong opinion. Maybe I should attenuate that a little bit, but what are your thoughts?
You mean you don't want to dump 20 mils of epinephrine down a small airway that has
Yeah.
ARDS in it? That's not ideal. But again, okay, let's check our bias. We know any delay in epinephrine is bad, and I'm going to do everything I can to not put epi down the tube. But is there any research to suggest delays in epinephrine would be worse than putting it down the tube? I don't think they've studied it, but the reason for the large volume of epi down the tube, because we know we need more volume for it to be absorbed in that area. But absorption's already kind of impaired in this state in pathology. And the HA guidelines and the ILCOR guidelines suggest like IV and IO routes are far superior for the circumstance. So it's like the last resort, as you said.
Yeah, just like how quick do you think you can pop in an IO, like a tibial IO, right? Compared to preparing all that medication, like throwing it down the tube, and now you've like gotten a tube first too, which is also not kind of what we're advocating for, right? So I think in most ACP practice, this is not really going to be something that comes up as much. And then because we talked about mitigating the airway with other tools while you get set up to give the epi through an IO or an IV, right? Um, so I think you'll be able to get access otherwise. But as a last ditch resort, of course, like it's in the guidelines, in the protocols for a reason. It is an option, maybe as like a first dose, and then you should work on the other ones. I just don't think, from like a logic perspective, in this case, that it makes much sense to do. Um, so it'll be suboptimal, but you can temporize with the suboptimal route, and then pop in your IO or your IV later on, I guess.
Hmm. I kind of like this mental gymnastics we're doing because we're trying not to be hypocrites. Because what if I don't put epi down the tube? Like, is that bad? And just because it doesn't feel good doesn't mean it's the best we can do at the time. Because again, if that's the only route you have, you got to do it, right? It's better than not giving it. But if we're looking at pros and cons and risk benefits, I like you said, the IOs have such a high first pass success rate and pretty quick success rate that I think it's a good option to focus in on that and let the airway be treated with just deep suctioning ventilations. That's my point of view.
Yeah, and we're talking about the IO being superior to this ETT. It's also really important to underline the fact that IV is superior to IO first. So we should definitely take a look at IV sites first. There are higher earlier ROSC rates with IV administration of epi compared to IO, as long as you're not delaying the administration of epi to try 3 IVs or whatever, right? So we want to talk about it like in terms of like a hierarchy of like vascular access, I think, or uh, routes for drug administration. I think like IV first, and then IO, and then if you're in some crazy pinch scenario, then it would be ETT, I guess, after that.
Okay. Can I play a game with you? Because I know people
Sure.
are probably thinking this. They're like, these guys are absolute nerds. Like, is this the way you think on calls? Because I want to see how you think on calls, and I'll tell you how I thought about it.
I try to keep things as simple as possible for the first few minutes of every call. I'm going to do them pretty much the exact same way every time because you're not going to try to reinvent the wheel when you're trying to manage your ABCs concurrently, quickly within the first few minutes of a resuscitation, right? Um, so I will put a tourniquet on an arm, look, okay, great, there's a solid vein, go for it. Okay, no, nothing really looks like it's a good option. I'm not going to delay and look around at that for much longer. I'm just going to go for the IO, and I think that's based on evidence for what gives us the higher probability of ROSC in these patients. When it comes to IV access, obviously, I'm going to prioritize a lot of things before that: high quality CPR, ventilation, defibrillation, right? But once those things are addressed, yeah, I will quickly move to IO, but I'm not going to skip that like genuine consideration for IV access.
That's my approach. And I'm going to unpack what you said because it relates to me. I think just being keenly interested in this and knowing that I could help patients in your decisions, you get so comfortable with it that you want to simplify it on the call. Like you said, it's like, I know that's the research, but to make it as simple as possible for this stressful event, I know just look for IVs. That doesn't work. Next step, IOs. Okay, the airway's not working. I'm going to try this, this, and this. Because imagine you're just sitting in the cardiac arrest thinking about, oh, I know that Epi's first pass success rate and the research said this. Like you'd be so overloaded that you wouldn't be able to function. So I love that you have this very simplified approach based on evidence, but also the comfort in knowing what to do because you've rehearsed this probably numerous times, right?
Yeah, exactly. So you're not thinking about the p-value between IO and IV when you are running a resuscitation, right? You've thought about that before. You've integrated that into a mental model and into the tactics that you're going to employ on scene, and then you do that. So no, I'm not trying to remember stats analyses and things like that from my research when I'm on scene, but it guides those decisions. It guides those tactics.
That's the point. The education helps support your practice, and what you see in practice will help support your education to learn furthermore. And you can see this cycle of them just supporting one another.
Absolutely, and there's always so much more to learn. So,
And I know we've talked about this before. We'll wrap up with this that like that's why it's good to have these conversations and your coworkers and just listening to their stories. Because if they present a case, it's like, oh, what would I do in that circumstance, or how would I react? Or even you just start playing this unrealistic game of what would you do then, or what if this happened? What would you do? It's already putting you into the mindset and the spot to think what you would do. So if it ever does happen or something similar is close to happening, you're like, I've thought about this before. I've thought about the risk benefits and how I'd apply my practice to the situation. So you're almost like you are one step ahead and you feel that comfort in knowing that I've troubleshooted this before. So I don't know if you found that during your career, but it immensely helped me.
absolutely. So knowing that, yeah, learning from calls that other people did by having those conversations in a really healthy way, I think is extremely beneficial. And then knowing that there's a lot of ways to run these calls, there's a lot of different orders in which you could do these procedures that are equivalent, and still good practice. But then deciding kind of the way you'd run it. I think another piece that's really important is think about how you're going to operationalize those things. Go look at the equipment and play with it to see how am I going to do this like in real life. Because I think sometimes we can skip that step a little bit.
I always remember this, and it's comical to say out loud that I was at a one day I was just practicing skills. It's like, why not want to review this again? And people looked at me like, oh, you're practicing? I'm like, oh, I'm sorry. Should I be practicing for run of the mill flag football league instead, or are we actually dealing with patient safety and high acuity skills here sometimes, right? But it's funny that goes back to the culture of like, yeah, we should be practicing, we should be supporting it because I never know when I will have to do this skill again, and I want to be comfortable at it.
Absolutely, and like I said, I'm really lucky. I think the environment around me and like the platoon that I work with, people are practicing. People are interested in doing scenarios together and things like that, and that's amazing. I think definitely should lead to a shift improvement in practice
Can I have a job out there?
for sure. You know who to talk to.
I do. He probably doesn't want me.
Thank you for watching. We'd like to remind this is separate from our professional roles and responsibilities. However, we do try to adhere to the highest quality evidence and rigorous standards. If you have any topics you want us to review, please let us know. Hope you enjoy.